Good afternoon. Welcome to today's discussion exploring how leading children's hospitals are using messaging tools to impact growth, burnout, and patient care. Maintaining strong connection and alignment across some of these large and sometimes complex provider networks certainly seems to be top of mind across the industry. And we're really excited today to dive deep with our panelists from Nicholas Children's Hospital in Miami and Wake Med Children's Hospital in Raleigh, North Carolina, to shed some light on their approaches. My name is Luke Gunter. I'm with Proficient Health, who is sponsoring this webinar, and I'll be moderating the discussion today. As a loose agenda, we'll start off by talking about some of the challenges that our panelists are seeing in aligning provider communities and how they're working to overcome some of the barriers that they've each encountered in technology adoption. And then we'll dive into the implementation of communication technologies and how that can impact and affect provider satisfaction and even physician burnout. Just a couple of quick housekeeping items as we're getting started here today. First is to ensure that you have the most optimal view on your screen. So you may be seeing a few different organizations of the content and the speaker boxes on your screen. In the upper right-hand corner, there's a drop-down that says View. And if you click on that, then you'll be able to see a couple of options. There's a standard format. There's a side-by-side speaker that will show just the speaker highlighted. And there's also a side-by-side gallery. That's the one that we would recommend as you're going so that you can see each of the presenters as well as the content. This is set up as a fireside chat, so there's not going to be a tremendous amount of content on the screen, but that would certainly give you the optimal viewing experience. And lastly, for the Q&A portion, we do have time allotted both throughout the presentation today, as well as at the end to allow for an open question and answer period. If you have questions, there's no need to wait till the end. There is a Q&A button there at the bottom of your screen that you'll use to submit. And again, we'll try to address them throughout as time allows. So once we get kind of to the end of a section, we're going to try and prevent that awkward situation where you ask questions and then we end up diving way back into the content later on to refresh and to answer. So if we don't get to your question during the webinar today, not a problem at all. We'll certainly follow up with our panelists and make sure that we get that information to you afterwards and make sure that each of you has the answers that you're looking for. And now I'm excited to get us rolling. That's probably enough that you've heard from me. I'll introduce each of our panelists here today, and I'll turn it over to them to introduce their organizations, and we'll get the discussion started. So first of all, we have Dr. David So with us. He's joining us from Nicholas Children's Health System down in Miami. And Dr. So is the Vice President and Chief Information Officer for Nicholas. In this role, he oversees information technology and communication services for the health system that includes Nicholas Children's Hospital, its network of outpatient centers, a medical group practice, and of course, other affiliated entities. Previously, he served as the Associate Vice President of IT and Chief Information Officer of the University of Miami Health System, where he also served as Chief Medical Informatics Officer and Chief Research Informatics Officer. Before moving into IT, Dr. So is a cardiologist and basic science researcher in cardiovascular genetics. He's a graduate of Duke University in Durham, North Carolina, where he earned his bachelor's degree and his medical degree. He completed his residency and internship in internal medicine at Beth Israel Deaconess Medical Center in Boston, Massachusetts, and then went on to pursue a fellowship in cardiology at Duke University Medical Center. And Dr. David Hoover is also joining us from Wake Med Children's. And Dr. Hoover is a practicing surgeon and director of pediatric surgery outpatient services at Wake Med. He is also Proficient Health's chief medical officer. And in his surgical practice, David is known for his innovation. One example, he was the first surgeon in the country to use magnets to correct the congenital absence of a portion of the esophagus. He brings that same spirit of innovation to his role as a physician leader, working to improve operational processes, efficiency, and patient satisfaction. And David co-founded MD Interconnect, a company specializing in mobile communication solutions for healthcare providers. He joined our executive team when MD Interconnect merged with Proficient Health in the summer of 2019. And David previously was director of outpatient specialty services for pediatrics at Jeff Gordon Children's Hospital. He earned his medical degree at East Carolina University, completed residencies at Northwestern University and Carolinas Medical Center, and was awarded a fellowship in pediatric surgery at Children's Memorial Hospital in Chicago. So Dr. So, I'd like to kind of get some introductions into the organizations. Would you like to start us off by sharing a little bit more about Nicholas Children's?
Sure. So thank you very much for the kind introduction. So Nicholas Children's Health System and Hospital is located, as I stated, in Miami, Florida. We are the only freestanding children's hospital in South Florida. We have a very large physician base. There are over 800 physicians and over 250 subspecialists who provide care at our facilities. We have over 45 different subspecialties that we care for as well. Sort of to give you a sense of scope, in 2019, which is probably the last sort of normal year since COVID, we saw probably over 280,000 outpatient visits, over 15,000 surgeries, and our inpatient admissions were right around 10,000. So that's sort of to give you a general sense of sort of the size and scope of our facility. And as mentioned, we have not just our main hospital, but we have about 12, over a dozen different facilities scattered throughout the South Florida region.
Okay, fantastic. And I think I see Dr. Hoover, if you've been able to join us. I know that you're fitting us in between cases. Are you there to share with us a little bit more about Wake Med?
Sure, absolutely. Good afternoon. Sorry about being a little bit late. As Luke said, it's my operative day, so I had multiple cases. But so Wake Med is a children's hospital within a hospital. We situated in Raleigh, Raleigh, North Carolina, and we are part of a 900-bed hospital system that is also affiliated with an ACO that's about 450 independent providers. Our children's hospital is the only one in Raleigh. Next door is UNC and Duke, and so there's a quaternary center there. We are a tertiary center. We don't do congenital hearts, but we do most everything else, from peds ortho to urology to peds surgery to we have a very busy intensive care and neonatal intensive care. The majority of our peds subspecialists are employed by the hospital, and I would say about 90% of our referring doctors are independent and privately held practices.
Fantastic. Well, Dr. Stowe, I'd kind of like to kick off with you a little bit of this conversation. And talking with children's hospitals, we often hear that communication with the referring community is difficult. Is that something at Nicholas Children's that you're really encountering? And what's the impact to that organization? How are you kind of addressing some of those challenges?
So it is a challenge, and whether in a role as a clinician provider or whether in a role as an IT professional, you certainly see all sides of the challenge, and it can be quite profound, and can inhibit being able to provide the best possible care. It can play a role in creating care gaps as we take care of our kids, and certainly can be a contributing factor that inhibits the growth of one's organization. It certainly creates a lot of dissatisfaction, and there really can be frustration on both sides, both whether you're the referring physician, it creates a lot of issues for you in your practice, but certainly even as a physician who is seeing the patient and trying to communicate back, it also can be a great dissatisfier as well. So certainly we can talk a lot about the technology components that go into it, but I would say that probably first and foremost, the operational groups have done a lot of work at Nicholas in order to try and close the communication gap between our providers and referring providers. And so we have a robust physician outreach arm that regularly visits and keeps up lines of communication, helps us to manage changes in personnel, perhaps at the practice. And it's really very important for us to connect not just with the doctors who refer to us, but very importantly, connect with the staff members who work in those practices, which are also very critical in the communication loop. We also have a robust group of sort of care navigators, and so they also close another loop between our providers and referring providers, also looping in families. So kind of that the triangle of communication between families, providers, which is also very, very important to help to also coordinate who is going to get tested where. So for example, if the referring provider would like to do testing or procedures outside of our facility, or if we decide to do it inside the facility, there really is a lot of communication and coordination assistance that the navigators provide, especially because many of our kids are very complex. They have a lot of comorbidities, and it really is a long-term relationship between our providers, referring providers, and the family. So really from a sort of operational respect, we do use specialized groups of people who create that connection that often technology is unable to fill very well, or with a process is unable to fill very well. And really, as you know, it can be very challenging because most communication these days still remains very asynchronous, in which whether it's an email or whether it's a phone call followed by messages and playing phone tag, it is in a rapid medical kind of process. These sort of asynchronous and slower methods of communication help to create some of those gaps. So again, operationally speaking, we have put in people whose job it is to help fill some of the gaps.
Excellent. And Dr. Hoover, you had mentioned earlier that you kind of sit as a children's hospital within a hospital. Are the communications challenges different in that setting? And why do children's hospitals seem to maybe struggle more than other hospital types, in your opinion?
I would say that children's hospitals don't struggle more. They're more attuned to the problem and the impact on patient care. And that may be a little bit of self-serving, that as peds specialists, we care more than adults. And I don't mean to come across like that, but in general, there is a more collaborative team management, as Dr. So has mentioned, with primary care and the subspecialist. The medical home has really been, I would say, the pediatricians and pediatrics has been on the forefront of the concept of a medical home, where the primary care giver is the captain of the ship and is really managing that kid on the outpatient basis and utilizing the subspecialists as needed, when needed, and more of a team approach. And so I would say that it is as communication has become more asynchronous, that goal has become harder to achieve. And also with the bifurcation of the medical world to the inpatient and outpatient, no longer do many of the pediatricians in any given market know the faces of their subspecialists. They used to come to the hospital and round on all their patients. That is now given way to the advent of hospitalists. They used to come, or a lot of them still maybe, but most of them don't come to the nursery for the newborn care. The economic pressures on the pediatric practices are such that they have realized it's hard to do that as well. And so we really have these two different communities that wouldn't recognize each other walking down the hall, but at the same time are communicating and caring for and coming up with these sometimes elaborate and very complex care plans for these complex kids. And so it used to be you pick up the phone, call the office, they knew who it was. Now you don't have that familiarity with the person, but you still are trying to achieve the same goal. So that is where the technology needed to evolve quicker than it has, I would say. In our institution, it's no, as a children's hospital within an adult hospital, I wouldn't say there's any different goals of that communication. But I would just say that we sit a little bit on the pinnacle of the medical home in the sense of it trying to achieve more real-time communication than a lot of times adults need to or have to. If you consider the fact that, an area may have 45 general surgeons and 2 pediatric surgeons. And so we're just a lot, there's fewer of us, we're a closer knit family, I would say, and we really see the value of this communication. David, do you have any, would you echo that?
I would agree. I think certainly having seen both worlds, I think that the concept of the sort of patient-centered medical home is really an apt concept, both sort of operationally as well as conceptually. And I would agree with you that there's more of a alignment around the mission, which is to take care of our kids. And I think that takes precedent over, say, let's say competition or trying to get market share or sort of some of the business perhaps considerations. And so I do think that there is more of a desire to collaborate and communicate better. And there are times, however, that almost makes it it actually highlights the gaps in communication sometimes even more, because there is more of a desire to communicate, and the fact it is harder to do sometimes is even more accentuated than what I've experienced before, perhaps in an adult setting.
Dr. So as you're kind of looking at those communications gaps and you look at the mobile technologies that you've implemented or that you will be implementing, kind of what's been your measurement for success? How do you see all of these different technologies working together at Nicholas?
So it's interesting. I think that before, when I've approached the issue of communications, it was really very process oriented. It was very much leveraging the EHR to do the heavy lifting as much as possible. I think that perhaps the bar was a bit lower as to what you consider to be effective communication. And I think, perhaps to some extent, we were being driven by meaningful use and other sort of, sort of regulatory and compliance guidelines as to whether you were meeting criteria or not. I'd say that, fast forward to where we are today with pretty much the democratization or whatever you want to call it of medicine, the same expectations that you might have thought were important before no longer apply. So when you can basically use a mobile platform to do all your banking, to make all your flight information these days, to actually do real-time communication with family members that are separated because of COVID, the bar of what you consider to be successful for communication today, it's very high, and it's no longer the same as before. So, and again, I think the other thing that's very clear is that sort of the heavy iron that all the IT shops in healthcare have been putting down and implementing over the years for whatever the motivations are, be it to meet regulations, what have you, those are really not fully sufficient anymore. They're not really built for that. And then there's a lot of sort of add-on or bolt-on tools that are in place, and they really are very specialized to meet different gaps that EHRs have. And so really nowadays, like I said, one needs to take a real holistic approach to thinking about communications. You have to have a much more broad thought process about who needs to communicate with whom and when. And it really needs to go beyond sort of being asynchronous. It really needs to be the same convenience that we all experience using SMS tools or other sort of messaging tools and sort of the non-medical world. That's really what the expectation is today. And you really, the frustrations now are, it's too slow. I can't speak to who I want to speak to. I can't add them to my group. I can't talk about relevant medical information. And so I think that's kind of what you're measured against today. You're really being measured against the existing consumer applications. It needs to be just as simple to use. It needs to be secure. And I think the final part of this, and I think it bears mentioning, is that to support this idea of real-time communication, when you want it, with whom you wanted to speak to, there is a significant need for a very robust data set on the back end, a data warehouse, a data lake, whatever you want to call your particular data store. It needs to be robust. It needs to be able to handle data in real time. It needs to be able to serve data in real time. And the final, I guess, part of this has to be, when you think about communication, the other sort of unspoken part of it is you have to have relevant data. That data has to be attributable to the person that you want to speak with. It needs to be validated. It needs to be, and so the process of keeping that data fresh has to be aligned with your communication tool. So again, it seems sort of simple on the outset to talk about using mobile to speak to people, but it's actually a lot goes into it, and the bar is very high, and the data has to be constantly refreshed. Workflows have to be aligned with that communication tool, because again, in the medical world, these communications can become very important for care. It can be, it can be a matter of somebody being taken care of very quickly, or somebody sort of languishing before they're considered. So again, the bar is high, and it's sort of over time has been more and more difficult to find tools that meet all these different requirements.
Dr. Hoover, I'd kind of like you to piggyback a little bit on that. I know that Wake Med has really been expanding its use of mobile technologies. How are you seeing them working together, and are you kind of setting a few of these same benchmarks that you're trying to get to?
Absolutely, thanks. I think that what Dr. So was saying that is so true is that what we're being measured against for success of communication really is your SMS texting, in a sense of it's that easy. And so everybody thinks it should be that easy in healthcare, and it should be, but it's a lot, as I've said before, when I'm texting my friend to go get pizza, it's really quick, and I know who I'm looking for, and I know the context. And the problem that we run into in healthcare, as I've gone back to it, this bifurcated healthcare world that we have an inpatient and outpatient, and then you drop on top of that, the inpatient world is so much team oriented. No longer is it just one person on call. There's 8 people on that team that are responsible for receiving some type of communication. And on the other side, that primary care doctor or the outpatient world is a lot of times shift-based, and they're not Monday to Friday. And so you have these concentric circles that aren't moving on the same pathway, you would say. And so if you knew who it was, and you knew if they were always available, and you knew when they weren't available, it wouldn't be hard. It would just be, oh, you just got to make it HIPAA compliant. But there's so many factors that come into that was a big reason that Wake Med, chose our platform, was because of all the different factors of the workflows, the team members. But then the thing that seems to trip a lot of places up is call schedules. And they have call schedules everywhere, and everybody's maintaining them. There's the lack of central truth, I would say. Who's on call and who's responsible for maintaining that? And when it's changed, how is that reflected throughout the institution? And Wake Med had a terrible time with that, in the sense of it was call schedules here and there. They were Excel spreadsheets. And the only person that knew it was the operator. Everybody else had to call the operator. And so our operators were being inundated just with the simple call of who's really on call and can you get them? And so that's why they when we saw this problem that was really communicated from the primary care doctors of, hey, y'all are great to work with, but you're hard as heck to get in touch with. And the primary and the specialists would say, hey, we love working with y'all, but we hate calling and getting that phone tree and having to talk to the front desk and be put on hold for 30 minutes while we're trying to do stuff in the hospital. So those are the two sort of loudest voices in the room, so to speak, of why they said, we got to have a platform that accounts for all these variabilities and enables when you reach out to, when you need somebody, that you'll get the right person at the right time.
We have had, Dr. So we did have a question come in related to, you had mentioned earlier in your discussion about some of the communication gaps that you're specifically targeting. And the question we had from the audience was, what sort of operational positions did you create in order to help fill some of those gaps?
So that's a great question. I think that if you think about, so I guess the way I think about operational problems is you kind of have to think about, well, when somebody wakes up in the morning, what do they think about? Like, when I go to work, this is what I need to get accomplished today, and that's where that's kind of how I define alignment. It's what's your major thing that you're thinking about? And I'll be very frank in telling you that physicians and clinicians, as much as we'd like to think that the thing they think about all the time is communication, it just, there's so much that goes into the job they do. I mean, look at Dr. Hoover's and Scrubs, like in between cases, right, to try and participate in this. So for us, the way we looked at it was sort of two different ideas. One was, how do we strengthen that relationship between our providers and referring providers to build that engagement and relationship with each other, so that it is like me calling Dr. Hoover and saying, hey, let's go get some pizza, or let's have a discussion about this. It's to build that rapport between different groups. And so that's sort of the outreach, physician outreach type of idea. And that's sort of one of the roles that we designated. And we did something similar to that at the University of Miami as well. It's that sort of physician liaison kind of role, build the rapport, make sure that we keep up with, what's the phone number, what's the fax number, and if we have a new communication tool, go ahead and do the outreach to get them engaged and trained. The second type of position that I think is increasingly becoming important operationally is the idea of a care navigator. It could be a nurse, it can be a clinical person, a non-RN, but this is now where you begin looping in the families along with the providers. So it's like I said, it's like a care coach, a care navigator type of role, and these can be obviously extraordinarily helpful with complex, chronic, long-term cases, as well as a surgical case. I think they're going to become even more prominent roles. I know Dr. Hoover, for example, spoke about that they're part of an ACO. I think these value-based care initiatives, as they come along, population healthcare, these all require and will need a lot more of these types of nurse navigator, care coach types of roles. I hope that answered the question.
Yeah, and as we kind of put a pin in this topic, I wanted to kind of get a quick hitter from both of you. So just really quickly, when you look, and we'll start with you, Dr. So, is kind of wrapping up, what's the biggest hurdle in aligning communications across the continuum?
So I think Dr. Hoover also touched on it. I would just say that it's just the multiple constituencies, and how do you connect all these constituencies in a secure fashion, in a real-time fashion, and how can you afford to do it? So Nicholas Children's Hospital, we are 76% Medicaid, so we are not rolling in the dough, so to speak. And so I can go and buy, there are tools that are out there that are literally high 6 to 7 figures if I want to really connect everyone. But I think it's the constituency issue. And Dr. Hoover mentioned it also, it's the attribution of that constituency to the communication and what's the schedule of that person. So because constituencies for me, and the way we think about it, it's not just the doctors and the referring doctors, it's also the medical assistants, it's the clinical assistants, it's the PT, it's the OT, it's the entire continuum of people who participate, and they can be administrative, they can be clinical, they can be support staff. And so how do you manage, how do you afford a really robust tool that it takes into account workflows and attributions, and you can literally open it up to everybody at your institution? It's a very difficult challenge that, to be honest with you, I've been struggling with for the past 10 years.
Excellent. And Dr. Hoover, you had mentioned in your last response a lot of the workflow challenges, the call scheduling challenges. Dr. So is pointing to some financial challenges in multiple constituents. Kind of, are there any others that you would point to, or where would you really prioritize that you feel like you've hit the biggest hurdles as you've been trying to tackle this challenge across the continuum?
So two things. One, I saw a question pop up about internal use. For your own physicians to communicate, and I think that it is important that so when we look at communication, inpatient, outpatient, vice versa, only about when we look at the places that we have our product, because to Dr. So's comment earlier, we have all the data. We know every type of communication that occurs, and if it is a new patient, existing patient, a new consult, we have all that, so we can look at the type of communication that's occurring and know that it's not Dr. So looking to have pizza with me. We know that it's truly about a patient, and if it's a new patient to the system. But the vast majority of the communication occurs on is inpatient to inpatient, because that's where your primary care doctor doesn't need to talk to a lot of other people during the day, whereas your surgeon, your cardiologist is managing multiple complex patients, will be talking to different teams. So having a product, a platform that fits the internal world of all the nuances of the team members, who's available, when they're available, call schedules and all those things, such that it works so well that the people in the inpatient side of the world are available when the outpatient side of the world needs them. And it's really that is the key to creating this community where everybody is on the same platform. Is you got to address the nuances of inpatient care. And I can tell you, the toughest place was the OR, in the sense of what is the use case that we're up against, as Dr. So said this early on, is SMS texting, or what we're used to. And what we're used to is I would go in the OR, I'd take my pager and put it on the table, and I'd go to work. If my pager went off, somebody would answer it and say, hey, it's this or this, and I'd tell them what to do. So then you say, okay, we want to move to a secure texting platform. Well, so some solutions are, oh, when you go to the OR, just make yourself not available. Well, one, people aren't going to remember to do that. And two, it's, what if I'm on call? I need to be available. And then you say, oh, well, then you just forward. Here's another solution people came up with. Just forward your messages to your circulator when you go in. Once again, people will forget to do it, or they go to a different room where you have 4 residents in there and an attending or a fellow and 2 residents. And so we had to come up with something that was just as secure, just as easy, have the data trail, to where now I go in the OR, I don't do anything, and it's on my phone, I don't have to do anything. The message goes off, and the nurse can go online on their account and pull up my message. We have a record of it and say, such and such is saying this, what do you want to do? They can respond for me, and I keep operating. They're not having to, so that is the biggest hurdle that EHR based communication platforms cannot get over, in a sense of what is their response to, we know you're not going to tell them, well, give them my password to get into my Haiku or my Cerner or my eClinicalWorks to look at that message. So, we had to figure this out, but because the surgeons were getting mad at me and yelling at me and everything else. I'm going like, you got to come up with a better way. And we were able to do it. But that's just one real time example of understanding inpatient clinical workflow and communication and the nuances that occur. But at the same time, if there's a patient, a pediatrician in the office that needs to get in touch with me, we want to make sure that they can get out in touch with me, but at the same time, not interrupt my surgery. So there's just a lot of those nuances.
And that's a great segue, kind of looking at the provider satisfaction side of things. And doctor, so we hear a lot from our clients and our prospects that there's a hesitation to move to, another way to get in touch with providers. And I know you've been looking at this recently, and as you were doing your search, did you hear those similar concerns on the provider sat front? And were you looking for ways to ensure that your investment didn't inadvertently create any challenges on that front?
Yes, so it applies to the physician, it applies to the IT staff, it applies to administrators. I think we've taken an approach where if you have another need that's not been filled and your current solutions can't do it, well, then we'll just buy another system and we'll buy another system. And certainly that's not sustainable in any front, but whether it's operationally or financially, and certainly doctors are not looking for something else. I would say that in general, anytime you talk to a doctor, they just don't want to think about it. I certainly knew that when I was practicing, I don't want to think about, okay, well, in this situation I have to use this, and in this situation I want to use that. And so, really, and really, if you kind of even take another step back, if you think about, well, why is it like that? Aside from the fact that the job is very busy, that's the process that we've basically followed. We just buy another tool and another tool and another tool. And the reason that you do that is because no one tool is actually able to do it. There's no unifying platform. So if I want to talk to this group, I need this. I want to talk to this group, I need this. And if I want to do that group, I need that. And so that's why we've sort of had this, proliferation of tools. So, for me, when I was thinking about from a communication perspective, I also was thinking about it from the perspective, okay, well, if I can now talk to every person on the campus, and then this physician can talk to any group on the campus, so then the next thing you get into is, okay, well then, can I begin to set up a way in which this group of people can talk to this group of people? Can I begin to replace some of the applications that I already have to do group communications or group messaging? And so, so again, yes, I got a lot of, well, David, I don't need another tool. So it really comes with, okay, well, I'm going to put a tool in that's not just for communications, it's for scheduling, it's for on-call schedules, it's to allow for group messaging that's maybe not completely clinical, right? So it did come to the idea of I do want to buy a part of a unifying platform that allows for many kinds of communications. It addresses many different constituencies. It encompasses, it accommodates multiple types of workflows, but it's a single tool. And so I do think that sort of got me beyond some of those, let us just say, strong opinions.
Yeah, absolutely. And Dr. Hoover, so WakeMed has a pretty robust set of communication tools in place for a while now. Have you observed that the kind of more tools becomes a driver of dissatisfaction? What are some of the more important things to consider when you're adding another communication tool to ensure that doesn't become the case?
I think the key is you want to minimize overlap as much as you can. And so there are, for instance, if your communication tool should really focus on communication, and take your ER or urgent communication, but the EMR may has a role for non-urgent, and so when you start saying, okay, we want to use our EMR mobile app to do urgent, and then you have another urgent one. And so I think when you have multiple platforms or devices that are trying to accomplish the same thing is when you really get confusion, and neither one of them become effective, because group A is over here and group B is using this one, and they're not communicating. So we know that there's no one singular, one ring to rule them all type thing. There's not one singular one that does this. But I think the challenge is to look at all the communication that is occurring within the institution and try to put it in, I would say, silo the type of communication, not the communicating people. And so, for instance, non-urgent, meaning, this is about a patient I saw in the office that the pediatrician needs to know what's going on. But it's not, it's one of those FYI, just keeping you in the loop. Here's what we're doing. That's a wholly different type of communication than I have a patient in the emergency department who's got belly pain. Then I have a patient coming in who has a stroke. 3 types of communication that have the same users, but different urgency or different time requirements and different goals of communicating. So looking at, and I'd say the other one is med staff information. We get 5,000 emails, but how do you get the most important one to the med staff about the fact that the hospital's full and we need discharges? So there are not only do you have clinical communication, but you have non-clinical communication. Once again, same set of recipients for the most part, but different goals. And I think that's a clear way to look at how you're going to use technology to accomplish those. And if you can take 3 of those 5 buckets and say this one does it and these 2 are going to be this way, then you've been able to pare it down to a much more reasonable thing than having 2 types in each bucket. And that's where you really get into trouble, is where you have multiple people trying to accomplish, let's say, urgent communication. And some people are using, one app, some people are using another app, and some people are using the SMS texting, and some people are using this. That's where you really, I think, get a lot of frustration from the providers, and you're not able to leverage your inpatient services as a outreach to your outpatient world.
Yeah. And Dr. Hoover, we just had a question come through that I'm gonna shoot back over your way. It mentioned that, does this require a referring provider to download the app on their phone as well? And if so, what's your experience been with that in terms of receptivity and in education?
So yes, it does require them to download the app. But once again, if you go back to what were the barriers to people using apps, it wasn't that they didn't want to use it. 1, it was cumbersome. 2, they found that nobody was answering the other end. And 3, they'd forgotten their login password because, most EHRs were saying you have to update every 2 weeks, have 2FA and all these other things. And so we sort of said, wait a minute, that's for an EHR, but this has access to a call schedule. There's nothing protected here. Why do we have to have them log in with a new password every 30 days or 60 days? So getting a lot of those barriers out of the way was one big thing. The second thing was making sure the inpatient world was there to receive it, and they got good and they had a good experience. But it doesn't cost them anything, and it's really no data or anything. And so once they start using it, and they tell other people about it, because it is so much easier and more convenient than going through the operator. The other thing that there was a big concern on the inpatient side was, oh my gosh, now they're going, the pediatricians or the family practice, the interns, they're going to bother me with everything. I'll never get anything done. And that is just the opposite. You get messages about patients that need to be seen, but you're getting notified earlier in their care, not when they go to the emergency department, but when they're still in the primary care doctor's office. And the primary care doctors are much more happy to use it, because they felt bad texting people all the time. They didn't know if you were on vacation, if you're at a wedding, on a holiday. And so just building a platform that was reliable made people want to use it. And like I said, they download on their phones, they download in the office, their office staff uses it. And it's easy.
Yeah. We had another one come through. I want Dr. So I want to ask you this one. So this came from somebody else in the audience. They said, how do you protect the relevance of your channels to prevent overload?
So I guess the way I would think about it, obviously, is this really is a type of thinking that we have today, which is, very different from what it was before. As I mentioned to you before, as I was sort of kind of thinking about what are people used to today, you are you are actually used to the SMS instant messaging world, and so the way you kind of find the balance is going to be, one, it's sort of organic, right? So between the provider and the referring provider, between staff and physicians, there's going to be that existing sort of practice of texting with each other, but now it's being done in sort of a secure fashion. And so I think to some extent, I'm not as concerned about overload in that, because it's very common today. It's become a very common practice today. And as an IT professional, obviously it keeps me up at night because none of these things are actually HIPAA compliant. Mm-hmm. And so to have an app that replaces and provides that secure communication, while also, facilitating a very commonly used practice today, it's a very, very key thing. I think that the second part of it is going to be, how do you keep your channels from getting overloaded? So, for example, I guess you'd be talking about how do there's currently email burnout, right? There's already burnout from these different kinds of things. I think just like with everything else, you have to have. So at our institution, for example, and also before, there is this concept of coordination as well between the operational sides. So whether it's training, whether it's communications, whether it's email, there's also the operational discipline to also sort of limit what you are really putting out there. Make sure that what you're putting out there is really important and relevant, and really reserve this for clinical and also sort of tangentially very, very important non-clinical types of communication. And so it really gets down to the issue of governance, discipline, and frankly speaking, who has access to do sort of group messaging or group non-clinical chatting. But again, I would say that again, this is common practice today. Physicians and staff and residents and fellows, they're all texting each other today. They're all using these different applications to do so. I think the next level of that is sort of your non-clinical communications and being thoughtful and providing proper governance as to what the tool is used for.
Excellent. And we've got about 10 minutes left here. I wanted to ask you, Dr. So you'd mentioned, I know that we had mentioned on the call that you guys have looked at moving forward with the PH Connect application. And during that process, you had mentioned that you'd been looking for a mobile communication platform for many years. Can you share a little bit on exactly what you were looking for, that maybe you were having trouble to land, and what it was on that Connect front that really convinced you to make the investment?
So kind of taking it from the provider clinician lens, as well as looking at it from the IT lens, I certainly, and my team and I certainly realized that a communication tool is more than just an app. So if we just needed the app, then I think Dr. Hoover had already made this point before. We could just figure out how to make SMS texting, do an in-house application. Their APIs exist. You kind of do these things, but I think that's a short-sighted view. So the other parts of it are making it widely available. So try not to limit the constituencies. Try to prevent an overlap of different types of communication. So it has to be a wide constituency. It has to be real time. It has to be HIPAA compliant. And the other parts of it is, we know now that we know this already, and it keeps us up at night, but people exchange photographs. People are exchanging other types of information. The other part that you have to pull into this equation is that we also have important core systems that also exist, such as the EHR. And as you begin to go through your permutations of, okay, well, this tool, we're just going to use it for simple texting. Well, as you begin to think through, well, that's, if you can do secure messaging, you can do other things that are important for the business and important for operations, discharge planning, consultations. You begin to sort of get through additional uses for a platform. And I think that the final part of it, as I've mentioned before, is that it has to be, I have to be a good steward for the health system. I can't sink all my money into a communication app either. And so it's sort of, what's the reach? And it's really about, it needs to be a platform. It's not just an application, it's a platform, which means what? It supports workflows. It can connect to your core systems. It can be, you can use it like a Lego. You can begin to, mix and match pieces that meet the goals, strategic goals of your organization. And then it has to have good, robust data that you can begin to mine. So there were a lot of different considerations that went into the decision making at which we arrived at moving forward with PH Connect. It really did check off all the boxes of what we were looking for in an application, and it's been extraordinarily well received at the places that it's been put in. It's an application, it's a platform that you just don't put it in and like nobody comes. It's very, very heavily used because it's intuitive, it's part of workflows, and so it like I said, it met all of the check boxes for us.
Fantastic. And Dr. Hoover, whereas Nicholas is kind of starting their journey, I know that WakeMed has been using tools for several years now. And so I've heard some really impressive adoption numbers kind of in that 90-95% range and above. And we're recently told that PH Connect was the single most important investment that WakeMed has made to affect length of stay. And so can you kind of share us a little bit more about having had this in place for a few years now, how it's affected your team and how your team is experiencing their workflows with PH Connect?
Absolutely. So I'd say, the integration with the EHR for delivery, real-time delivery of consults, and having a robust data reporting and backup system, and has been was one of the biggest impacts on length of stay. We found that rounding physicians would say, okay, we're going to consult cardiology, and they'd put the order in CPOE, it'd hit the unit secretary, they'd try to call them, nobody'd answer, a few hours later. And so there was a 4 or 5 hour delay sometimes for a consult to then initiate to when it was received. And by instituting, having it all hooked up with the EHR, it's now an average of about 2 minutes to where the consulting physician is notified and all the data is put back in the chart of who, what, and when was notified. And so right there, when you start looking at a 900-bed system and you're dropping your average consult notification time from hours to minutes, you're starting to impact length of stay in a big way. And so I'd say that was one just very tangible way that we were able to track and show that delivering over 5,000 messages to all sorts of services, inpatient and outpatient, really made a difference. It's freed up unit secretaries. They're not having to find people anymore because the inpatient world is on the platform, and all the ACO and all the community doctors have it. No longer are they going through the call centers and you're having the operator connect you. So that's freed up FTE allocation for our operators. And then I would say some unintended things that we never knew would happen. The biggest example is our orthopedist came to us and said, hey, we have a lot of athletic trainers we use, that are in the community for the soccer and football games that call us. Is there any way we can set up a role and get all the athletic trainers on it? Said, absolutely. And so they got about 40 athletic trainers that regularly use them on the app. We made a special role, and it didn't require them to be any more available. It still went to the orthopedist on call, but all of a sudden the athletic trainer could send in a pic of a kid's ankle to the orthopedist, and they could get them in the next day. And the unintended thing that also happened was all of a sudden the athletic trainer would be in the gym, and their buddy who is, just torn up shoulder lifting or something says that's how they'd send those guys into, or females in too. So it was in the first few months after they did this, they ran the numbers, and it was in excess of a few $100,000 of difference and just additional revenue that nobody ever knew would come just by making them taking down the barriers of access. We didn't make the physicians any more available. We just removed some of the access barriers that existed. And so that story has been recreated over and over again with the dietitians, with SNFs in the community, that they hear about it. They want to be able to connect easily to the providers. And so the fact that it Weight Med can give this app out as many times as they want, and it doesn't cost them another penny, enables it to have that broad adoption in the community.
We're getting pretty close. There's one question that's also come through, and I want to ask each of you to maybe spend 30 seconds or a minute on it. But really, it seems like there's a broad theme coming through about do we get or anticipate pushback from those community providers when you're looking at adoption? I think we touched on it briefly earlier, but Dr. So I want to throw it to you really quickly. And is that something that you've experienced as you've been implementing more tools and potentially looking at this rollout with Connect?
So I would say that I have not gotten pushback, and I'll be honest in telling you, I don't expect to get pushback. I think that again, one of the roles that we talked about earlier were these sort of the physician outreach role, and we know from both that role at Nicholas as well as in my prior institution, we do know when these folks go out into community, communication is probably one of the top 3 issues that these referring physicians have problems with. And they don't want to sign into an EHR. They don't want to have to do yet another piece of paperwork to try and get a communication done. That they want to just get on their phone and they want to call somebody or they want to text somebody, and they want to know with whom should I communicate. And so to provide them with a tool that will enable them to do that, which is basically as easy to use as any of the current existing platforms, the consumer-based platforms, which everybody's already using. From my prior experience in rolling out different EHR-based tools, there was never any pushback. It was always well received. It wasn't highly used, but it was very well received. I would expect in this particular instance, it will be very well received and highly used. And so again, I don't expect and I don't anticipate any pushback.
Okay, fantastic. And
I'll say one thing along on that. Yeah, real quick is that when you're implementing something like this, you're always going to have a bad experience with somebody, in a sense that they used it and for some reason nobody called them back or got in touch with them. And so our team that's involved in this process is monitoring those interactions, and we reach out to the person that didn't get the message and the person who sent it and address what happened. And usually it's a workflow issue that we need to institute, check a call schedule or something like that, so that they have a positive experience. Because what we found is if they have positive experiences initially, they will continue to use it and continue to promote it. And success builds success.
Fabulous. Well, that's going to wrap us up for today. On behalf of Proficient Health and everybody that joined us, I'd like to extend a big thank you to our panelists. That discussion's been tremendous. For anybody that would like to follow up with our panelists or see more of PH Connect, Rhonda Dowdy's information is there on your screen. She'll be your conduit at Proficient Health to get anything that you need or would like to see. So thank you again for joining us. And if you did enjoy today's content, please be on the lookout for our second installment coming this year in June. We would love to see you then. Thank you all.